Top Med Talk.
Welcome to Top Med Talk. This piece is a question and answer session on the subject of perioperative care. It's divided into two parts, and this is part one. It's hosted by Dave Selwyn, Deputy Medical Director at Nottingham University Hospital's NHS Trust and Director of the Centre for Perioperative Care. Also, co-chairing, we have Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton. On the panel we have patient advocate Lawrence Mudford. He's enjoyed a 38-year healthcare career working as a dentist and dental educator within both primary and secondary care. Also Stephen Evans, Centre for Perioperative Care Fellow and Anaesthetic Trainee, ST7. You'll also hear being introduced Sophie Randall, Director of the Patient Information Forum, and Scarlett McNally, Deputy Director for the Centre for Perioperative Care and Honorary Clinical Professor at Brighton and Sussex Medical School and Consultant Orthopedic Surgeon in East Sussex. We join them as they take questions from the online audience. Previous parts of this meeting are also available in the show notes.
Thank you, Steve. And if I can just invite members of the panel to come and pick a chair, any chair. And I'll just introduce a couple of additional members. So delighted to be joined by Sophie Randall. Thank you, Sophie. Sophie is the Director of the Patient Information Forum, so we hopefully brought a strong patient voice for you today, so we'd like to unpick some of that. And also Scarlett. Thank you for coming, Scarlett, breaking a holiday. Consultant Orthopedic Surgeon in Eastbourne. I was a member of College Council, the 9th female member of the Royal College of Surgeons of England Council. Got that right? And you're President-elect of the Women's Medical Workforce Federation. There you are. But most importantly, you are a Deputy Director of CPOC. Excellent, we're agreed on that. Lovely. Mike.
We have a lot of questions. This may take a little bit of getting through, but I think the first one, Lawrence, is probably teed in your direction, but if others join in. How do we engage patients who are looking to you to make all the healthcare decisions as they are shocked and have no idea what to do next? I think this reflects on your account of how you felt when you first heard your diagnosis.
Yeah, thank you very much for the question. It's a really difficult one, isn't it? Because at the end of the day, we need training almost in psychological profiling of our different patients that we actually see. And every patient reacts differently. You'll have the quiet ones who don't ask the questions. You'll have the very verbal ones who want to know absolutely everything. And guess what? You've got a very short space of time. I spent the evening with a general practitioner last night who was explaining to me you've got 60 patients in the day in general practice in your day list, and you do that every day of the week. So it's a really difficult problem. Part of the problem, I think, is that we've grown up in the United Kingdom particularly with this idea that you go to somebody and they tell you what to do. And that's a really useful thing 50 to 60 years ago, but it's not quite as appropriate now. And so we need to build into everything the time that a patient actually needs to actually sit down and listen to what they actually want and find their goals and their aspirations. And actually try to just pull back a bit from doing what we all do, because I'm a problem solver by background, I suppose, and I'm great at giving advice to people, often when they don't actually need to do it. So I've learnt that I've got 2 ears and 1 mouth. I need to shut up more and I need to listen more.
Okay, so these will jump around a little bit, but there are some themes which we might come back to in a little bit. Regarding lifestyle choices, how do we as clinicians manage the effects of deprivation on health? Are we failing our most vulnerable patients?
Yeah, I think this is quite interesting. We've just been doing some work on this with the co-production group. Can
I just say, before Sophie says anything, after my comment earlier, she did point out that this week is the 7th year for co-production week in the United Kingdom. So I'd just like to clear that controversial mark that I did before.
I'm only teasing. I do think sometimes we put academic terms on things that then do make them kind of like isolating people. But actually, what that really means, co-production, is talking to people about what they want and need and listening to them. And I think with a lot of the stuff we've been talking about lifestyle changes, particularly for some of those people who maybe are experiencing deprivation, are more likely to smoke, are more likely to be overweight, it can feel very judgmental. So it very much depends on how it's framed. But I also think from this work that we've been doing on the MSK pathway, one of the things they said that should be a marker for shared decision-making, good shared decision-making, there is no surprise at the end, and that a lot of these conversations should be starting much earlier in general practice, which is why the sort of combination of all of that data from different records that Jugford Deep was talking about is so important. I saw a presentation up at NHS Confed, which was saying actually anyone who smoked, looking at Pilot in Leicester, where they are treating smoking status as a disease in general practice and targeting it to stop people doing it. So I think it's about providing the support for people, often though they're in very difficult circumstances. One of the things that came across really clear to us from the patients that we've been working with is that actually to make a lot of these lifestyle changes, they have to get their head in the right place first, and that can be a real challenge. And actually somebody saying to you, for example, you're too fat to have this operation in a sort of very blunt way, can put somebody into a spiral of emotional overeating. So you've got to be careful and think that these things happen in a much wider social context, and provide support for people and be sensitive to the judgment that they feel. So a lot of it is about the tone of the conversation.
So I might just build on that. So I think this is really difficult, which is why we haven't really cracked it very well. And I'd be interested from the international views whether anyone else has made better inroads into this. I think there is that spectrum of patients. Now, there's also a bit of a societal change that perhaps we need to start to have. A bit of a conversation about, it's all very well having passive healthcare, but what about taking a bit of responsibility and ownership and a bit of active healthcare? And certainly in some of the documents we're starting to produce, I know Scarlett was talking about the anemia guidelines yesterday, we started to specifically put that out there, that actually we need to get some patient responsibility, to take some responsibility, be that being more active, be that looking after your own health. And it's part of the deal to providing healthcare. Now that's a very different place than we've been currently. And this feeds into all of those difficult conversations about the health inequalities, the prevention agenda, population health. And again, all those things that we haven't really tackled, but we must, because otherwise we're not going to be able to cope. I mean, Steve's graph of the people getting older with the greater number of comorbidities.
Yeah, I completely agree, because unless these things get tackled, then health inequalities will persist. But it's a question, I think, how it's done and the support that's put into people earlier in their pathway, earlier in their journeys. I mean, a lot of this is driven by poverty, and without other structural changes, it's very difficult to change that. But I think the other thing that we see is that people become very disempowered and feel unable to make those changes. So I think having this wider professional matrix is really important, and bringing in those third sector organisations and using social prescribers and really targeting those areas with those earlier interventions and sooner, and doing some of this in school as well, much more so.
So I might bring Scarlett in, and then I just want all of your ideas.
Thank you. Yes, sorry I'm late. I was with my mother, who's 87, got dementia, had an operation last week, and everything's fine. I'll talk about that later if we've got more time. I was lead author for a document called Exercise, the Miracle Cure and the Role of the Doctor in Promoting It in 2015, and I thought that would be the answer to everything. People just needed to read it and then we'd get on with it. But actually, and it did have a chapter on how to get started, because behaviour change is incredibly difficult. But all the things that make people better before an operation, and if you want to get your surgeons interested, you mention complications. You go, do you want to halve your complications? Every surgeon, when you mention complications, goes slightly white, feels a bit, they think about the one time they wish they hadn't done that. You've got to harness that, and that will get them on your side. But all the things that halve complications are the same things that improve your life, reduce the impact of diabetes, heart disease, all that stuff. And there's a finite number of things, and it's smoking, exercise, nutrition, alcohol, drugs, pollution, psychological empowerment, getting enough sleep, that kind of thing, which I appreciate is a bigger thing. But it's a finite number of things, and each of those is tackleable. And the problem is the NHS anyway is very passive. As you're saying, you come and you get your treatment, and that's what people want. But I think people don't quite get that it is possible. A little bit of change makes a huge amount of difference. But we need to start small and build up. Although, it should be patient responsibility as well. We need to change society so that it's normal, so it's accepted. And for now, because we haven't got environments that allow people to go for a walk or, eat vegetables and things, we need to get people's friends and families involved and helping so that they know this is part of the deal. So my niece is taking my mother to her hospital appointment now, and she knows that she's just got to get her there and all that stuff. You need to bring in the family and the culture because people can't do it alone. It's very difficult to make a big behaviour change if you're the only one doing it, and it's too hard for everybody. That's not how human brains work, is it?
Yeah, the erosion of family unit, that's an interesting point in this country. There's a question here. We've got some roving mics, so if I can just get your...
My name is Birgitte Bransford. I'm from Denmark, outside Copenhagen.
And a surgeon.
Oh, yes. I understood that you wanted to start a new society on perioperative medicine. How do you plan to organize it in relation to the ERAS programs?
It's not a new society. It's a qualification which sits alongside the training program. It's a little bit different. It's for trainees or anyone really that wants to pursue a formalised interest in perioperative care. There's obviously lots of stuff out there at the moment which people are doing. It's all fantastic that people can do postgraduate diplomas and certificates and so on, but this is more of a formalised process which should, this is our ambition, formalise what a perioperative physician or a perioperative specialist or a generalist looks like in their training.
And the other thing, just in my hospital, we actually do research in the difficult conversation. It's on the surgeons to give that information to the patient often. I always been against the term the conversation singular, because I think it should be plural. But things are really happening and we are taking courses on how to do it and so on.
Can I just come back on that, actually? It's very interesting. I think we're looking for exemplars. We're looking for programs that actually work really well and that can be shared. So one of the innovations on the St. Guy's, St. Thomas's POPs course is they invited me as a patient to come and speak in their training pathway for doctors and for nurses. And I think that's just a very simple option that courses can do. Pull somebody in who's got the experience.
Okay, did you want to come in?
Just a couple of reflections on the communication thing. One is the determinants of health story. What we do is relatively unimportant. It's maybe 20 to 30% of the overall attributed risk for various health problems. And so a lot of what will be important is influencing politicians to change the rest of it, which is about social environment deprivation, air pollution, etc., all those things. The other was a reflection on our experience in a slightly different context of patient engagement around the research agenda in my day job at Southampton University, which is that we have often been spectacularly unsuccessful at engaging with the communities that we've been desperate to engage with. And the two ways that have worked, one been through our research cohorts, so people who, whole diverse group of people who have the conditions and are engaged already. And the other has been through the very simple approach of going to our community leaders and saying, we don't really know how to do this. How can we do this? Because and that might be faith-based community leaders or local geographical communities, but just I'm sort of with Lawrence, sort of forget the co-product, just how do we do this? We would really like to work with you to make it better, but we honestly don't know how, so can we just make it up together?
Can I come in on that? Because we have our production, we have guidance on co-production and how to engage with people, but fundamentally it's just about starting small. It doesn't have to be some massive designed process. It's about going to where people are and talking to them and seeking their views, seeking how they want to engage, and finding out what's in it for them as well to engage. And I think particularly when we're talking about minority community groups at the moment, who are a bit overwhelmed now with sudden requests for co-production because of the health inequalities agenda, that actually they've got very limited capacity and quite often they need some support for that work as well themselves. So I think it is just about going openly and really listening, and fundamentally when you do listen, do something with that knowledge that you've come back, because otherwise it becomes a kind of meaningless process. Then that builds trust and people will take that relationship forward. And it can be just some of these simple changes around tone of voice in material that is put out for people, or the way you have conversations, how you personalise it for different ethnic groups, that can make the difference.
Another question? Or?
Yeah, so have a look at Slido, because as a reflection, there's awful lot of questions and comments, and some of the tone feels slightly different from previous meetings we've had, and I don't know if that's a post-COVID thing, but I'll take an example. I don't think desperation is quite the word, but there's a definite feeling of how on earth are we going to do all this stuff if we are so overstretched with everything we have to do normally. Yeah. So if I start, we need time for shared decision-making in this current climate of need for increased throughput. How can we manage this conflict?
Okay, so let's take that question, because one of the questions I was going to ask Lawrence was, well, when in the pathway should we do shared decision making? So let's take that one and then talk about the time, and I'll bring in Scarlett probably into that.
So that sounds like a slightly loaded question, because of course it should be right the way through every stage of a patient's journey, shouldn't it? Yeah. But there are some pinch points where I think they're really quite important. So I can remember one of my relatives having a great hospital experience before they actually had an operation, where the shared decision-making process went brilliantly, and actually they had time to do it in the hospital system. If I give you an example of where it went very badly for the same member of my family, a district nurse came in after this person had had an operation for cancer. They had a major operation, and the nurse came in, district nurse came in and said to this person, "You're going to have chemo because it's really good. They've done so much for you in the NHS. It'd be a shame not to have chemo as well." So there's two examples of where shared decision-making in a hospital situation and out in the community are dealt with in very, very different ways. So it is time, but it's also training as well for the whole profession, so they understand how to talk to patients about shared decision-making.
Scarlett, let me bring you in about your practice and your thoughts on trying to make that headspace, what we could do differently or what we could stop doing, radically thinking.
I mean, the difficult bit is I'm an orthopedic surgeon in the south coast of England, and things have become too streamlined almost. I'm supposed to make a decision, see a patient the first time, make a decision, put them on a waiting list, fill out all the forms, do the consent form, and then not see them again until the morning of surgery. And we're not allowed to bring someone back for a second chat. And I think part of the problem is that I'm not good enough at that, or human brains don't work like that. And ideally, you'd have a consultation and give people things to think about and then come back and have another consultation. And I've started doing that, and I'm being monitored on my new to follow-up ratios because that's how the NHS works. That's one thing, just to say that's the context. And we kind of assume that the surgeon will make the decision, but actually, I think the pinch point idea is a really good one, Lawrence, because you don't want everyone doing the shared decision making. You don't want a receptionist having an opinion or whatever. But what you do want is them to go, actually, that's a good point. You've got a holiday, you want to go, bring that up, mention that, write it down. We need to encourage people to come with, this is what's important to me kind of things, of what you want to do, what you want to achieve. But we need to get people into that mindset of thinking about it beforehand, because otherwise they come justifying, I've got this pain here, and it's really horrible. When I do that, it's really horrible. I need an operation because it's horrible. You can't do the, yes, I'm sorry, it's horrible, and I've got an operation, but it might make you worse at the same, it feels like wrong to do it in the same mindset. So we need to, I think, have the ability for people to come back and have another conversation, but equally, we need the other members of the team to know when they can slip in and have that discussion. I used to work with a physio in the next door room, and I could hear what she was saying, and she could hear what we knew what we were going to say when we referred people to each other. Because I was saying, well, if you don't mind waiting in the waiting room for a bit, we'll see if Sarah might be free later. She's a whiz on this, and she'd have the discussion, and then they come back to me and go, actually, I think we'll try something Sarah suggested. We don't do that enough. It's not, the multidisciplinary it's all in our little individual locked rooms to be confidential or something, and actually what we need is to use the team and to direct people. And I have the receptionist handing out how to get fitter for your operation, and the healthcare assistants, and the simple things that people can do for themselves, and that everybody should be on the same pathway. And there's real intense shared decision making for the people that have the information. Perhaps.
Okay, thanks, Scott. I might just bring in Denny. There's something about the documentation, isn't there, of that discussion as well, which I suspect we're not very good at.
Thanks. I think it's a really good point about educating patients about shared decision making. We talk a lot about educating clinicians, but we run a shared decision making clinic for specifically patients where we're all aware that it's going to be a complex decision. So patients that the surgeons identified, and we sometimes run them joint with the surgeons, some majority on our own. But one of the things that's really clear is what's important. The quality of the conversation is affected by what the patient expects when they come to that clinic. We've started a campaign across our whole trust, and we've gone for the Ask 3 questions. You can go for the brand, but it's advertised in all of our outpatients, which is, the 3 questions are, what are the good things and the bad things? What can I expect from my operation? What are the alternatives? And where can I get more information? That's now going out with all outpatient letters, because I think, as you said, we like to give advice, but also some patients come thinking, as you said, Scarlett, we're going to get an operation or not, and I'm here to fight for my operation, and haven't even thought that those things are relevant. So I think it really helps if, some education campaigns for the patients to prepare for that. And then the other thing about the time question, I really think we've got to utilise our resources. Every decision should be underpinned by shared decision making, but some conversations with shared decision making are relatively brief because it's completely obvious what the right course of action is, for all concerned. And that small group of patients, which is a small group, who utilise masses of healthcare resource when they come in, they're the ones that spend ages in hospital, they spend a lot of time in critical care, where the risk and benefit is really marginal. That's where we need to make sure we have a space to give those patients the additional time, which is why we've now started a separate clinic. I know John and Mike's walked down and Torquay have done that for a while. So that for the high-risk patients, when we know it's going to be difficult, we can make a longer appointment, because you can't have those discussions in 10 minutes. It doesn't work. And the final thing is, I think it's really nice if they've not been told what they need as an operation before they come. Because, once the patient thinks that is the golden egg, you're taking something away from them. Whereas, they've never been given, doing nothing is only a bad option in that conversation. Whereas if it was introduced at the very beginning, or alternative treatments, even if you don't know what the risks and benefits, you might say it will involve other members of the team for the oncology. If you say at the beginning, what you need is an operation, now we're going to see if you're fit for it, that's the wrong conversation, the wrong way to start a conversation, I think.
I'm Jamie, Southampton. I'm an anaesthetist who runs a clinic on a Wednesday afternoon every other week and have these difficult conversations with patients. This is really difficult, and lots of people are not trained in it. That's part of the problem, that you learn how to do this. I'm not very good at it, so I'm getting better with each sort of 6-month period that goes by. And I think Mike Swart will probably have a lot to say on this. You get better at this over time, and so many of us are so poorly trained in it. I've got a couple of colleagues who are doing this regularly, who are absolutely brilliant, much better than I am at it. And I think as a collective, Steve spoke about who delivers this, who does perioperative care. We need to commit to training to be better at it. Surgeon, anaesthetist, it doesn't matter doesn't matter what label you are or what label you've been given through your training. All of us can always get a bit better at it. And I think I've learned how bad I am at it at the moment, and how much I've got to learn in terms of getting better. I think that's a key point.
Yes.
I'm going to jump in. We've got a lot of questions on Friday.
Okay, Denny, just very quickly, you didn't introduce yourself, but...
We surveyed the whole trust, about what they thought about shared decision making. And the bit that I find in the training, this is before we did some training, is that everybody's very good at telling patients about risks and benefits. The bit that everybody's terrible about, and not only are they terrible at, but they didn't think it was part of it, because they rated the importance. So down at 20% was listening to patients' values. And, 99% was telling them the risks and the benefits. And they think they do shared decision making because they tell you the risks and the benefits. Most of us need to improve in the listening to what's important to patient, and not only the listening, but actually thinking that that's important. That was very unimportant to our surgical teams, I think, particularly, I have to say. Sorry.
Right, thanks, Danny. I think good points.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.